So action potential, when we talk about action potential, you must understand there are two main different action potential we need to know. One is peripheral nerve action potential, action potential that developed and propagated in a peripheral nerve that causes muscular contraction, which is skeletal muscle contraction. For that, you need a stimulus. Okay, you need a stimulus, as in, let's say there is a hot pan or hot cup there, hot coffee. You suddenly hold it without realizing it. The temperature, the heat is the stimulus, which is sensed by your nociceptors in your fingers. So that stimulus will cause an action potential at the peripheral nerve, which will propagate it along the nerve root and goes to the associated motor unit, which causes the muscle contraction. When you talk about cardiac muscle have something called intrinsic properties, which is automaticity. So where their stimulus to contract comes from intrinsic, which is called as your SAN node, sinoatrial node. The sinoatrial node is working, not working, it will be taken over by other conduction system in your heart. Sinoatrial node to bundle of E's, Purkinje fibers, then ABN. So all these are conduction system. So one is malfunction, another one will take over. Okay, so this SAN node called as own potential, SAN potential, or called as a pacemaker potential. Pacemaker means intrinsic properties that keeps the heart beating on its own. So that's why in a denervated heart also, when there is no nerve supply to the heart also, heart will still beat. Okay, so SAN or pacemaker potential. So this pacemaker potential will be propagated along the cardiac muscle, causing ventricular contraction or atrial contraction. So we will go through that. So before we go into the effect of the action potential, we have to start from the basic. So I've talked about axon that day, the parts of a nerve, peripheral nerve. We talked about axon. So axon will have a myelinated and non-myelinated, where the conduction of the nerve impulses will be propagated along the nerve. So we have a peripheral nerve. This is your peripheral nerve, axon. You have a membrane. So membrane got extracellular and intracellular. Okay, so we know that extracellular has abundant cations such as sodium and calcium. Intracellular has abundant cation as potassium and magnesium. Okay, so what does this cations distribution important is? They are important for to determine the action potential, depolarization and repolarization, and what is the resting membrane potential value. How does this cation actually determine the resting membrane potential, and when there is a stimulus, how these cation movements are altered so depolarization can occur. So if you look at it, this is axonal membrane, intracellular, extracellular. So if you look at it, this is axonal membrane, right? So this will be extracellular, here will be intracellular. So if you look at it outside extracellular, you have higher concentration of sodium and potassium. Sodium and calcium. Intracellular, you have more potassium compared to your sodium and calcium. So you have to know this distribution and what is the concentration. Sodium concentration in extracellular is 150 millimole. Sorry, milli equivalent per liter. Intracellular is 15, which is 10 times lesser. Extracellular is 10 times higher. But potassium, intracellular is 150. Extracellular, which is in our plasma, is only 5, which is 30 times higher. The concentration gradient is 30 times higher for potassium compared to sodium, which is only 10 times different. Okay, so sodium is abundant in intracellular. So what is the importance of it? So it comes to resting membrane potential. So if you look at it, this is axon membrane, right? So as I mentioned, sodium is more outside, potassium is more inside. So resting membrane potential is a steady state potential which exists across the cell membrane. Resting membrane potential of a typical myelinated peripheral nerve axon is negative 70 millivolt, with inside of the membrane being negative with respect of the outside. So why is it so? Why inside is negative even though there are a lot of potassium? So we go back here. We see how many cations here. Sodium 1 plus and calcium 2 plus. Sodium 1 plus, calcium 2 plus. Potassium is 1 plus only inside. So that's why outside is more positive compared to negative. Compared to inside. So inside is relatively more negatively charged. Intracellular component is more negatively charged relative to extracellular component, because extracellular got cations that have a higher positive particles. Okay, so you must understand that. So how does this cation distribution are maintained? So we have sodium potassium pump, we have sodium voltage gated sodium channel, we have voltage gated potassium channel. This channel, this potassium and sodium channel alone, not the pump, I'm talking about the sodium channel and potassium channel, they allow diffusion of the ions across the membrane along the concentration gradient. So extracellular got a lot of sodium. So sodium from higher concentration goes in intracellular passively. But since they are positively charged particle, their diffusion is not strong or faster as non-charged particle. Charged particle will take longer time for diffusion. Same goes to potassium. Potassium from intracellular will diffuse out to extracellular. Since potassium concentration is 30 times higher, the gradient is much higher, potassium will leak out more compared to sodium that comes in. Okay, so that's another reason why potassium concentration is still higher outside, because less sodium is coming inside rather than the sodium that going outside. Sorry, let me correct it. More potassium is going outside, less sodium is coming inside, so still more positive particles outside. So now we talk about sodium potassium pump role. What does they do here? So when you talk about step 1 in establishing the resting membrane potential, what happens is the sodium potassium pump pumps sodium out of the cell, and K plus pump intracellularly, means it pumps the sodium out. Why is it need a pump? Because now we are going across the concentration, against the concentration gradient. Now when you look at the potassium voltage gated channel and sodium voltage gated channel, they are diffusion, they are going down the concentration gradient. Higher sodium to low sodium, higher potassium to lower potassium, in, out, out to in for sodium. But what does sodium potassium pump does? It is a pump which is driven by ATP, sodium potassium ATPase pump. So it's an active transport. So what they do, they transport the ion against the concentration gradient. So even though sodium is higher in extracellular, but the sodium pump still pumps out the sodium from the intracellular to extracellular. Potassium pump concentration is higher intracellular, but still the sodium potassium pump pumps in. So why is it important? To maintain the resting membrane potential where negative intracellular and positive extracellular. So the negative resting membrane potential will be maintained as negative 70 inside, relatively inside. So how much of sodium being pumped out? 3 sodium being pumped out, 2 sodium being pumped in. 3 sodium go out and 2 sodium come in. Okay, creating a action potential. Okay, so this is the other way around. Sorry, so that's important. So you understand this part. So what happened? This pump will create this situation where more positive ion outside compared to intracellular, leading to resting membrane potential of negative 70. Okay. Next step, the membrane is permeable to sodium and potassium. These ions tend to leak across the membrane down the concentration gradient. This is what I mentioned just now. Sodium potassium pump actively pumping out against the concentration gradient. and but the sodium and potassium channel are going down the concentration gradient. As I mentioned, the membrane is 100 times more permeable to K plus than sodium. 30 times, the concentration gradient is 30 times more. So more K plus loss from cell than sodium enters the cell. Net result, larger amount of positive charge has left the cell than has entered it. This is what I mentioned, larger positive cell outside. So that makes the resting membrane potential negative. This charge distribution is referred to as the resting membrane potential. This is how the resting membrane potential value of negative 70 comes in. So what are the factors that contribute to it? One is the sodium potassium pump, which pumps out 3 sodium outside and only 2 sodium in, and sodium potassium diffusion, in which potassium permeability is much higher compared to sodium, and the concentration gradient for sodium potassium also is much higher than sodium. Okay, next, after we have the resting membrane potential. So if you look in a graph, this is your resting membrane potential, negative 70. This is the place where a nerve is at rest, nothing is happening. Okay, now we have a stimulus. As I mentioned an example just now, you touch the hot coffee suddenly. Okay, so there, when that's the development of an action potential start from the resting membrane potential. So the peripheral nerve membrane, as I said, stable membrane potential of a negative 70. This is the resting membrane potential. Membrane is exposed to a current. Current means either stimulus or current lah, anything. The membrane potential can decrease, become less negative. So what happens is, when there is a stimulus, that causes this resting membrane potential to go high. Why is it mean? This is via the diffusion of the sodium and potassium, where the sodium is going in. The sodium is going in. When there is a stimulus, the stimulus causes this slow sodium channel to open. Slow sodium channel to more open, so more sodium comes in. So more sodium comes in. When the more sodium comes in, intracellular become less negative or more positive. So what happens here? Becomes slowly more positive. Slow sodium channel opens, and sodium influx causes intracellular become less negative, goes until it reaches a threshold. This is called as a potential threshold for action potential. Okay, threshold for action potential. It reaches a value for the threshold potential 55. At this area, the sodium channel will open. Voltage gated sodium channel, the fast sodium channel will open. When the fast sodium channel open, so reaches a threshold potential, sudden opening of fast sodium channel, sodium influx. There is a sodium influx. This sodium influx causes the sudden depolarization. It means the resting membrane potential from negative value will suddenly surge up to a positive value, almost up to 30 plus 30 millivolt. Okay, so that's what happened. So depolarization of the membrane, phase 1. The membrane potential overshoots and reaches potential of 30 to 35 millivolt. Inside is positive. When we talk about potential, the value always will concentrate on the intracellular value, not the extracellular. When we say resting potential, membrane potential negative, it's an inside value. When we say positive, also inside value, because more sodium has went inside. Electrical gradient for, so the moment it reaches a 30 to 35 millivolt, when it reaches here, the sodium channel closes and the concentration gradient now will reverse. Okay, so what happens is reverse. The membrane potential overshoots and reaches a 30 to 35. Electrical gradient for movement of sodium now reverse. Earlier, with the sudden opening of the fast sodium channel, a lot of sodium went inside. So now there is electrical gradient reaches inside positive, relatively outside negative. Now it has to reverse. The moment it reaches a overshoot of 30 to 35, it will reverse, where the sodium channel will close and potassium channel will open. Potassium channel will open, causing more potassium to move out of the cell, because there are higher concentration of potassium inside, 30 times more, right? And the sodium channel, potassium channel open, potassium will efflux as much as possible to bring out the resting membrane potential again. Means inside must be negative again. So since the sodium channel has closed, sodium cannot go out now. Sodium have to rely on the sodium potassium pump. Sodium have to wait because this sodium channel already closed, because already reached a potential value of 30. So now these, they only have to rely on these to go out, but this will take time. But what happened during that time? Potassium channel opens and all the potassium goes out very fast, making the resting membrane potential negative again. So in summary, the sodium pump sets up the initial concentration for sodium and potassium, the resting membrane potential of -70. The differential permeability of the membrane of these two cations are responsible for differential leak. Okay, this is based on the concentration gradient and the permeability of the potassium being higher than sodium. The unequal charge separation resulting from the resting membrane potential is called the pump leak hypothesis. Okay, the pump is leaking based on the concentration. The actual RMP at any time can be determined from the Goldman equation. Remember this for your MCQ. The equation includes the concentration and the membrane permeabilities of all the charged species present, means all the cation present. The concentration and membrane permeability. For concentration wise also, potassium has a higher concentration intracellular. Membrane permeability also, potassium has a higher membrane permeability. 100 times, 30 times. Concentration 30 times, membrane permeability is 100 times. The ion that contribute most to the RMP are those who have the following properties: higher concentration present, large transmembrane concentration gradient, large membrane permeability. So potassium have all these things. Actual RMP in a nerve cell not much different from equilibrium potential for potassium, which is calculated by Nernst equation. Please remember this as well. How do you want to calculate the RMP for equilibrium potential? Is by Nernst equation. Goldman equation also can calculate it. Okay. So again, we go through this. As we have discussed that day on antiarrhythmic, cardiac muscle action potential got phase 0, 1, 2, 3, 4. But in skeletal muscle action potential, there is no number 2. There is no plateau. Why? The most important thing or most striking difference here is in skeletal muscle on peripheral nerve action potential, there is no role of calcium. You see, even though I mentioned here, extracellular got higher amount of calcium, but during the development of action potential in a peripheral nerve and skeletal muscle, there is no calcium involved. There is no calcium movement for the skeletal muscle action potential. For skeletal muscle contraction, yes, that is different. Okay, that is different. This is for action potential. For the nerve impulse propagation and development, there is no role of calcium here at the moment. You see, that's why there is no plateau, because in cardiac muscle action potential, the plateau is maintained by the calcium influx. But here, there is no calcium influx. That's why immediately potassium channel open, potassium efflux, and then repolarization starts. There is no phase 2, which is a plateau phase. Resting membrane potential maintained by your resting potential. Then this part is depolarization by voltage gated sodium channel. You see your sodium comes in, sodium comes in, sodium comes in. Your sodium potassium pump is not doing anything. Repolarization, voltage gated sodium channel. Sorry, this is the potassium pump. This is your potassium channel. This is a sodium potassium pump. At this moment, it's closed. So the potassium is coming in, sodium is coming in, no sodium is going out, sodium only coming in, depolarization occurs. Then at the overshoot, already reaches 30 millivolt, repolarization occurs, where potassium is going out, sodium channel closed, sodium potassium pump is still closed, so repolarization occurs. Graph comes down to resting membrane potential again. Then at the to maintain the resting membrane potential, both sodium and potassium pump is not actively working. The sodium potassium ATPase pump is started working, pushing out the higher sodium which is already built up just now, pushing out actively, and then sodium potassium is coming back again. Okay, please go through this with the word that I've written here with this, along with these pictures. Again, resting membrane potential of -70, there is a stimulus. If the stimulus is not strong enough, let's say you touch the coffee, hot coffee mug, but it's just warm. It's not, that's why you didn't withdraw your hand. It means that stimulus, heat stimulus, is not strong enough to activate or reaches the threshold potential and thus activate a action potential. You hold the cup with the warm coffee, it's just warm. That's why you are not withdrawing your hand, you're still taking up the cup. It means there is no withdrawal reflex, there is no muscle reflex. It's not strong enough. The stimulus is not strong enough. It's a fail initiation. Doesn't reach the level of threshold to cause an action potential. It means your muscle contraction to occur. But if it's very hot, you touch, you immediately get, it immediately reaches the threshold potential and causes action potential. The action potential will propagate along your muscle and strong enough to cause a muscle contraction. That is the difference. So stimulus, initially slow sodium influx, reaches a threshold, sudden opening of sodium channel, sudden sodium influx causes depolarization, reaches an overshoot of 30 to 35, electrical gradient reverse, sodium channel closed, potassium channel open, potassium efflux, repolarization occurs. At the part when there is already negative below the threshold, so sodium potassium pump opens again and then establish your resting membrane potential. Again, sequence of events here. Resting state, all gated sodium and potassium channel closed, only the sodium potassium pump is working. Okay, then depolarizing phase, sodium channels open. Repolarizing phase, sodium channel closed, potassium channel open. Hyperpolarization phase, what is hyperpolarization? This is hyperpolarization. If it's when we talked about resting membrane potential being negative 70. If it go even below negative 70, it means hyperpolarized, means sodium channel remain open while the potassium channel remains open, causing increase in sodium potassium efflux. Okay, prolonged opening of potassium channel causes hyperpolarization where your resting membrane potential goes below minus 70. Okay, below minus 70. This is about resting membrane potential. Okay, so how it get propagated from one axon to another axon. So this is neuron 1, your axon of previous neuron. Then from here, there is a synapse. From there, the action potential propagated to another one. Electrical signal being propagated to another one. So how it happened? The brief period of local depolarization of the membrane has effects on the surrounding cell membrane. So from this membrane, this axonal membrane, it will propagate to the next axonal membrane. How? It acts as a current sink, which causes the potential of the surrounding membrane to decrease also. So imagine this is the first axon, this axonal membrane. So when there is an action potential being developed here, that will cause the nearby axon threshold resting membrane potential to rise slowly to reach the threshold potential. Again, sorry, yeah. So this is the, let's say there is another axon here, already reaches the axonal potential here. This will stimulate a current sink on the next axon where this will slowly rise and reaches a threshold potential, and the next axon also will cause to have a propagation of action potential. So it acts as a current sink which causes the potential of the surrounding membrane to decrease also. One axon already developed a proper action potential. This proper action potential will act as a stimulus for the nearby axon to start opening the slow sodium channel, and the resting membrane potential slowly will become negative and reaches the threshold potential, and thus that axon will start having another action potential. So this is propagated from one axon to another axon. So with this decline reaches a threshold potential, the surrounding membrane also briefly depolarize. This process is repeated, and the net effect is the movement of a wave of depolarization and repolarization down the axon. The propagated change in potential is known as the action potential. The sodium and potassium channels are voltage gated channels, mean they open and close in response to specific membrane potential. Voltage mean there must be a change in electrical gradient, the millivolt. They are potassium and sodium voltage getter. They are not as the same as your ACH receptor or your G protein coupled receptor. They are ligand gated. They need a ligand. For nicotinic ACH receptor, the ligand is the ACH. They are not based on electrical gradient. They are not based on the millivolt. Okay. They don't open or close based on the millivolt. They are based on the ligand. Okay. Oh shit, I used my own thing. I didn't ask Peva, so it's gonna close. If it closes, we will do another, we'll continue. I will re-log in. Okay, so next is axon. So this is what I mentioned, from one axon to another axon. This axon, it always moves from positive to negative, positive to negative. From this axon, it moves to the next axon, it moves to the next axon. The action potential continues to travel down the axon. You see, positive to negative, positive to negative, positive to negative, positive to negative. This is the depolarization area. So when it moves to the next one, this one will repolarize. Next is resting. So when resting membrane potential achieve a threshold, it will go to a action potential. So this already moved here. This is repolarizing. This will come to a establishment of resting membrane potential. Again, repetition. You can see sodium influx causes, the moment sodium influx, action potential happens. Then sodium comes in. Then potassium efflux causes the repolarization. Okay. Next. Okay, these are all peripheral nerve action potential. The skeletal muscle action potential is exactly same morphology as your peripheral nerve action potential of this. Exactly same morphology. But only difference is your peripheral nerve action potential is very brief. If you look at it, this is very brief. 1 to 2 seconds. From here to here is only 1 to 2 seconds. It's a very brief period of action potential. But your skeletal muscle action potential is slightly longer, where it can go up to 5 to 6 milliseconds. So that's the only difference in the morphology and what are events that occurring in peripheral nerve action potential and skeletal muscle action potential. They are only involved sodium and potassium. They only have phase 0, they only have a resting membrane potential, depolarization and repolarization. They don't have plateau. There is no calcium involved. Okay, but only difference is skeletal muscle action potential is longer compared to skeletal peripheral nerve action potential. That is only different. The major differences are between skeletal and cardiac muscle action potential, where we're going to talk about now. So next, another thing, just for brief, no need to know a lot. There are also smooth muscles, right? You might be asking about smooth muscle action potential. Smooth muscle action potential, where are the smooth muscle of situated? Like in your vessels, like in your bronchus or your uterus and everything. They have something called spike potential. Okay, the smooth muscles occurs as a spike potential. Okay, so spike potential, the thing is they are even longer compared to your skeletal muscle. They can occur from 10 to 50 milliseconds, just taken as a contraction of your uterus in a pregnant woman contracting. Sometimes the contraction can go up to 1 minute also, right? So that is the difference between smooth muscles and skeletal muscle. Skeletal muscle contraction cannot go that long. You will get exhausted because it's ATP dependent. Smooth muscles are not like that. Okay. The smooth muscle spike potential can be generated by electrical stimulation, hormone, neurotransmitters stretch spontaneously on its own. Okay. So this only this much you have to know about smooth muscle action potential. It called spike potential, action potential with plateau. They can have a plateau also. Longer duration, delayed repolarization results in prolonged contraction. This is smooth muscle action potential. Let's remember these differences. Next, we go to heart. So heart has pacemaker potential and ventricular muscle potential, ventricular action potential. So when you talk about pacemaker action potential will have sodium, calcium, and potassium. We have sodium, calcium, and potassium. It also does not have a plateau phase. There is no plateau. It has a resting membrane potential, depolarization phase, and repolarization phase. What's the difference here is in the depolarization phase, the main ion involved is calcium, not the sodium. Sodium is involved in the initial depolarization phase, which is as a slow depolarization phase. This part, slow depolarization, which is involved a sodium channel called funny sodium channel. They call it as a funny current or funny sodium channel, which is very specific for SAN or pacemaker potential. So you see again your resting membrane potential of 70, 60 minus 70. I've explained why is it so. So why happens is there is a funny current sodium channel where it allows the influx of sodium slowly. So that will makes the pacemaker to reach a threshold of negative 40, less negative. The moment it reaches less negative, calcium channels open. Calcium channels open, making a rapid depolarization up to positive 10 to 20. Once it reaches there, the electrical gradient reverse, where calcium channel close and voltage gated potassium channel open. Almost similar to your peripheral nerve action potential, but only difference in peripheral nerve, this whole thing is caused by sodium. But here, only the early part is caused by sodium. The main depolarization, the spike is caused by calcium because it's heart. For heart, you need calcium contraction, calcium for contraction. Other than that, the morphology is almost the same, but there is a slow depolarization by sodium up to the threshold. After the threshold is calcium. Okay, so it's almost similar to ventricular action potential, right? Ventricular action potential also needed calcium during the spike, but there is no plateau phase again. Okay, next. So we look at it, action potential in pacemaker cells. We have a funny sodium channel, we have a calcium channel, we have a potassium channel. So during this part, when there is a pacemaker potential, initial part, this is the funny sodium channel open, where sodium comes in. Sodium comes in, sodium comes in. The threshold potential reaches slowly, means the resting membrane potential from minus 60 slowly become negative and reaches minus 40. Minus 40 is the threshold potential. The moment reaches threshold potential, calcium channel open. Calcium channel open, calcium influx. Calcium influx, sudden depolarization. Reaches a positive gradient, positive electrical value. This part, calcium channel also closed, potassium channel open, potassium efflux, repolarization occurs. Okay, these are just repetition. Can go through it on your own. They explain accordingly. 1, 2, 3, 1, 2, 3. The 2 year is not the phase 2. It's not the phase. The 2 years we're going to event, second event like that. Okay, don't confuse with that. So what you have here, the phase is usually 0, 3 and 4. Okay, 0 is your depolarization, 3 and 4 is your repolarization phase, the hyperpolarization phase. Okay, 0 is your depolarization and 3 is your repolarization phase. Okay, so next we go to cardiac muscle action potential that we discussed that day during the antiarrhythmic. I'm just going to go through it very fast. The difference being here, the resting membrane potential of a cardiac muscle action potential is much negative because of the calcium. Okay, because the calcium is involved, the inside is relatively more negative because calcium also involved here. So calcium and sodium outside more positive, inside only potassium less positive. So that's why inside more negative. So it can go up to minus 90 here. So with the minus 90, again initial part, opening of voltage gated sodium channel causes the first spike. Then transient out of flow of potassium causes a early small repolarization. Then your maintenance of plateau by L-type voltage gated calcium channel. Then finally your calcium channel close and potassium channel remain open, causes repolarization. So we look at it here. In cardiac muscle action potential, cardiac muscle, this is pacemaker potential, SAN. This is the ventricle muscle, myocyte, cardiac myocyte. It involves fast sodium channel. Here is just funny sodium channel. Here it's called fast sodium channel, slow calcium channel, and slow potassium channel. Okay, sorry, potassium channel. So what happens here? In the initial part, here is your fast sodium channel. Okay, Then here will be your potassium. Blue is blue, potassium. Then action potential. So the difference is the fast sodium channel, calcium channel that maintain the plateau. This graph goes according to the color of the sodium channel here. Is orange here but yellow here. So the sodium channel. So look at it. This one we have discussed the day. So I'll just, so the early spike, the spike or depolarization is by the sodium channel. Early repolarization by the sodium channel opening, but it's maintained by plateau of the calcium channel opening. At the end, repolarization occurs by opening of potassium channel being remain open, but the calcium channel closed, so repolarization occurs. Okay, difference again. Resting membrane potential is more negative in cardiac muscle because of the calcium involvement. There's a sudden surge because of the opening of voltage gated sodium channel. There is an early repolarization, which is not seen in the action potential of pacemaker or in skeletal muscles, because there's a but there is a plateau is more important here because the calcium channel involved. And the duration is very, very long, up to 250 millisecond. Okay, that's the main difference. Okay, so early depolarization, main effect is by calcium, very small effect by major effect by sodium, very small effect by calcium. Early repolarization because of the potassium, then maintenance by the calcium, then repolarization by the potassium. You will have an absolute refractory period where there is cannot be another action potential or another contraction to occur. Okay, a second action potential cannot be initiated during this period because there is a plateau maintained by the calcium channel, and then sodium channels are closed during this period. So for you to have another action potential, you need sodium channels to be open. Okay, sodium channels are not open, that's why it's called a absolute refractory period. Again, we went through this the day. The resting membrane potential is up to minus 90 lah. Just remember, it's more negative compared to skeletal muscle because of the calcium. Okay, so again the repetition. Okay, we talk about this propagation of action potential from one axon to another axon in a nerve or in a skeletal muscle. But how does it occur in cardiac muscle? So you have to know the distinguishing features of a cardiac muscle versus skeletal muscles. Please read Carrie Brandy. There is a table explained very well. So the most important in a cardiac muscle cell is ventricular muscle cell as something called gap junction. This is gap junction. You see, this is one cell, this is another cell, ventricular muscle cell. They have, the myocytes have something called gap junction. So via which your calcium can diffuse or move across from one cell to another cell. Okay, so the movement of calcium from one cell to another cell is how this threshold potential is reached. Okay, the ion movement, the positive ion movement via the gap junction from one cell to another cell is how the action potential is propagated from one ventricular myocyte to another myocyte in the heart. It's different from your peripheral nerve or skeletal muscle action potential, where they are rely on a current sink. But here it's via the gap junction. There is gap junction. And your skeletal muscle or peripheral nerve, they need the external stimulus. They need a stimulus like a heat. They need a stretch or something like that to cause the action potential to be developed. But here, your heart, something called autorhythmicity. Your SAN, your sinoatrial node or AVN or bundle of E's, all the conduction, they have autorhythmicity where they can generate their own pacemaker potential. This pacemaker potential will cause ion movement via gap junction and maintain your ventricular myocyte propagation of action potential. Okay, so another thing you have to know is superimposing your pacemaker potential on your ventricular muscle action potential. You can see it's much shorter atrial pacemaker, which is SAN pacemaker. There is no plateau in your SAN pacemaker. Okay, so your SAN or pacemaker potential is total around 150 to 200 millisecond, but your ventricular action potential can go up to 250 millisecond. And your resting membrane potential of your pacemaker potential is around -60. Your ventricular action potential is even more negative because the involvement of calcium. Okay. So pacemaker action potential, cardiac action potential, you see in your cardiac muscle action potential is 0, 1, 2, 3, 4. Here 0, 3, 4, 0, 3, 4. Okay, only 0, 3, 4. Depolarization, repolarization, resting membrane potential. Here resting membrane potential, depolarization, early repolarization, plateau, and proper repolarization. Okay, occurs in pacemaker cell driven by funny current sodium channel, unstable RMP, only 3 phases. Autorhythmicity is possible, present. Occurs in ventricular muscle cell driven by stimulus. The stimulus comes from the SAN. No funny sodium channel. They have fast sodium channel. Stable RMP of -90. 4 phases as a plateau. Autorhythmicity not possible. They have to rely on the gap junction, which is sodium or calcium movement after initiation by the pacemaker potential. So next, this I take from Kerry Brandeis. You all can read it on your own. There's a nice table explaining all the differences. In your Osce, they might ask you to mention 1 or 2 differences. Very, very important one to remember is the duration. There is no second phase, which is a plateau phase, and then maintain about the RMP, which is more negative. Okay, these are 3 main important striking differences. RMP, ventricular muscle cell, is more negative. I'm reiterating many times so you can remember. SAN or pacemaker is -60. Duration, ventricular muscle 250 to 150. Then the phase 4, sorry, not phase 4, the phase 2. Phase 2 is not present. Okay, plateau phase 2 is well formed. Okay, phase 2, phase 3 cannot be distinguished. Here only 0, 3, 4. Here 0, 1, 2, 3, 4. Okay, sorry, here 0, 0, 3, 4. Here 0, 1, 2, 3, 4. Okay, so these are all okay. Now the differences between skeletal muscle and your cardiac muscle. You look at your skeletal muscle, as I mentioned, the duration is very short, 5 to 10 millisecond. Cardiac is 250 millisecond. Again, no pre-plateau. There is no pre-potential. So here got a pre-potential. In cardiac skeletal muscle, it just shook like that. Okay. So read on your own. All these things are differences. Okay, next we go to adrenal gland. Very quickly, Leven asked me about it. I hope that I understand what she asked. So adrenal gland, we have 2 adrenal gland. Very quickly about your anatomy. You have a capsule. You have 2 main layers, cortex and medulla. My cortex is divided into 3 different layers. So where is it? Right and left, suprarenal, above your upper pole of your kidney, present on the both sides. It's a retroperitoneal organ at the level of T12 vertebra, thoracic 12 vertebra. It has a protective fat pad. It divided into cortex and medulla. As I mentioned, cortex, there's a cortex, and this part is cortex. All these are cortex, and then medulla. Okay, cortex has 3 layers. We remember by the mnemonic GFR, which is glomerulosa, fasciculata, and reticularis. GFR. Okay, outside to inside. Okay, GFR. And all these layers produce different hormone, including your medulla also. And why we have to know about adrenal is very important in hypothalamic pituitary adrenal axis, HPA. Hypothalamic pituitary adrenal axis, which is involved in neurohumoral endocrine system. Basically, the whole body is involved in this. The hormones that secreted by adrenal is very, very important, and is very important for your feedback of your whole endocrine system in your body. Briefly on the vascular supply, each suprarenal, each adrenal is supplied by 3 arteries: inferior phrenic artery, middle suprarenal artery from abdominal aorta, superior suprarenal from inferior phrenic, and inferior suprarenal from renal artery. So superior suprarenal, middle suprarenal, and inferior suprarenal. The origin is from inferior perineum, abdominal aorta, and renal artery. Vein, a single vein emerges from hilum of each gland, drains into right side directly onto inferior vena cava, left side into the renal vein. Remember this. Next, three different cortex got glomerulosa, fasciculata, reticularis. Glomerulosa secrete mineralocorticoids, fasciculata secrete glucocorticoids, reticularis secrete androgen or sex hormones, or adrenal medulla secretes your catecholamines. Okay, so the layers cortex make up to 70% of the whole adrenal medulla, adrenal gland, and medulla is only 30%, 70% and 30%. Out of this 70% cortex, 50%, the larger portion is your fasciculata, 15% is glomerulosa, 5% is reticularis. Okay, this part out of 70%. GFR. They produce mineralocorticoid, glucocorticoid, androgen. How to remember? I remember salt becomes sweet, becomes sex. Salt, sweet, and sex. Salt becomes sweet, becomes sex. Sex is androgen, and medulla produce your catecholamine. Again, repetition. The percentage that given here are in 100%. Okay, here don't follow the percentage given in this picture. This is wrong or not so accurate. Follow the one that I've given here. Okay, this one. This is proper. Okay, don't follow. This one is to say what produce what. The mineralocorticoid mainly is aldosterone that you have to know. Fasciculata produce glucocorticoid, cortisol. Androgens, they produce estrogen and testosterone, everything. Catecholamine, they produce epinephrine, adrenaline, norepinephrine, noradrenaline, and dopamine. So we go to synthesis of mineralocorticoid and glucocorticoid and this one. What does the cortex produce? So cortex produce salt, which is aldosterone, produce sweet, which is glucocorticoid, cortisol, and then sex hormones. So how they produce? The very famous question is the precursor for all this. This happens in glomerulosa. This happens in fasciculata. This happens in reticularis, GFR. So the precursor is cholesterol. There are multiple enzymes. The important enzyme for you to remember is 17 alpha hydroxylase and 11 beta hydroxylase. These are two main important enzymes you must remember. So from here up to here is all same until 17 alpha hydroxyprogesterone. Then they take a different route to reach out to different. Okay, please remember this: 17 alpha and 11 beta hydroxylase. Why? This is what the enzyme your etomidate inhibit. Your etomidate inhibits your adrenal cortical system because they inhibit these two enzymes, especially your 17 alpha hydroxylase. So they will stop your aldosterone or cortisol or catecholamine production and your aldosterone and cortisol production. So in a patient with septic shock, you will not have compensatory mechanism involved. Your glucocorticoids is important in your septic shock. That's why patient with septic shock, high inotrope, we give glucocorticoids. We worry the adrenal system is not working. That is the reason etomidate is not suggested in septic shock patients. So this is another way looking at the synthesis. Here from here they divide in three. If you look at it here, it's the same. They divide it in this way. This way is all your glomerulosa, your mineralocorticoids directly the main system. From here, it will branch out to develop 17 alpha hydroxypregnenolone or progesterone, which goes to cortisol. Here, from here, to go to androstenedione, which goes to estrogen and estradiol. Your testosterone is in your peripheral tissues. Please read up on your own. Try to remember the important, as I mentioned, 17 alpha and 11 beta hydroxylase. Next, we go to medulla. Okay, so we talk about cortex. Now we go to medulla. Medulla produces catecholamines. So what are the catecholamines? As I mentioned, catecholamines are epinephrine, norepinephrine, and dopamine. So this is your catecholamine synthesis. So your catecholamine synthesis starts with phenylalanine. Okay, phenylalanine. That is your precursor. So phenylalanine will undergo hydroxylation by phenylalanine hydroxylase, become P-tyrosine. Tyrosine will undergo tyrosine hydroxylase, which is a rate limiting step. Very important MCQ question. Rate limiting enzyme in this synthesis is tyrosine hydroxylase. Goes through DOPA to become DOPA. Then DOPA become dopamine by DOPA decarboxylase. So first catecholamine you get in your body is dopamine. Okay. Dopamine undergo beta hydroxylation to become norepinephrine. and your norepinephrine undergoes N-methyl transferase, become epinephrine. So dopa become norepinephrine, become epinephrine. Okay, tyrosine hydroxylase is important because it's a rate limiting enzyme. For catecholamine synthesis, this simple is enough. No need to know extra. This is the simplest. Okay. So this is what the same thing. Why I showed this is tyrosine hydroxylase is the rate limiting step. Dopa decarboxylase is the pyroxyl 5-phosphate dependent enzyme, which is your vitamin B6 pyridoxine. In a patient with vitamin B6 deficiency, you won't get your catecholamine synthesis properly. Your dopamine beta hydroxylase is copper containing enzyme. So all this you read on your own lah. So what I want to show is this part, and this is a bit of complicated way with your structure. If you go to primary, you have to write the structure for pharmac. You have to know the structure in pharmac. If you do a TPAC, it will be mentioned the exact synthesis with the chemical structure. But for physio and your level, this is more than enough. Remember these and these enzymes. Next, we go to metabolism of catecholamine. So these are synthesis. So how your adrenaline and noradrenaline being metabolized. Okay. So adrenaline and noradrenaline, first enzyme you have to remember is COMT is catechol O-methyl transferase. Catechol O-methyl transferase with the undergoes methoxylation, become meta-adrenaline and meta-noradrenaline. Catechol O-methyl transferase, and both of these undergoes MAO enzyme, monoamine oxidase, oxidation to become vanillyl mandelic acid. So this is your final metabolite of metabolism of your adrenaline and noradrenaline. Okay, sorry that I have to go a bit too fast. I don't want to take up your time. I want to let you all to go do your self-reading. Next, effects of catecholamine. I'm sure you all know this. Catecholamine, based whether it's adrenaline or noradrenaline or it's dopamine, they all have here different effects, either via alpha agonist effect or beta agonist effect or dopamine receptor effect. So that I mentioned that day, GQ, GS, and GI all have different effects. Please read about it. This is for you for your reference later. What I want to show is this part. They have beta effect where they cause increase in heart rate and contractility. Beta 1 effect. Okay, beta 1. Inotropy and chronotropy. Okay, inotropy. This is chronotropy, inotropy. Increase in cardiac output. They have alpha 1 effect. Noradrenaline causes vasoconstriction, venoconstriction, venous return, increase cardiac output. They have effect on your kidneys where you can stimulate your aldosterone to have your sodium reabsorption involved in your renin-angiotensin aldosterone system, RAAS, renin-angiotensin aldosterone system, where it causes sodium reabsorption and water retention, increases your body volume and increases your BP as well. And it also causes arteriolar constriction, vasoconstriction, increases your peripheral vascular resistance, SPR. So your SBR increase, your MAP will increase because your MAP is equivalent to cardiac output times your SBR. So cardiac output increases by this part, SBR increases by this part, and your blood pressure increase. So this read up on your own, this part. I'm not going to go to this. This is why I want to talk to you about hypothalamic pituitary adrenal axis, HPA axis, hypothalamic pituitary adrenal axis, or hypothalamic pituitary adrenal axis, HPAA lah. Okay. So what it means your hypothalamus secrete hormone called corticotropin releasing hormone. This corticotropin releasing hormone will stimulate anterior pituitary to release ACTH, adrenocorticotropic hormone. The ACTH will stimulate your adrenal cortex to release your cortisol. Okay, this is to talk about cortisol. So not the aldosterone, not anything else. We are talking about cortisol. So cortisol level in your body will give you a negative feedback to inhibit anterior pituitary to release further ACTH or to inhibit hypothalamus to release further CRH. So cortisol can cause negative feedback to anterior pituitary and hypothalamus. Okay. So this is HPA axis. So how do they affect? So you can see here your sympathetic nervous system. So we start from, sorry, this is your renin-angiotensin aldosterone system that I mentioned. Okay. So what is important in renin angiotensin aldosterone system? You have your hypothalamic pituitary adrenal axis. Your ACTH stimulates your cortex, zona fasciculata, and zona reticularis. Okay. So what does they do? They stimulate cortisol, glucocorticoid receptor goes through this, androgens and effects here. So your adrenal cortex, zona fasciculata and fascicularis, adrenal medulla, sympathetic nervous system is your adrenal medulla, right? So adrenal cortex, what happens in adrenal cortex is your cortex will release your aldosterone. Okay, so that will involve in your renin angiotensin aldosterone axis. So what does this aldosterone do? So this aldosterone is sorry. So angiotensinogen will stimulate undergoes through by renin enzyme goes to angiotensin 1. Angiotensin 1 undergoes conversion by ACE, angiotensin converting enzyme, to angiotensin 2. This angiotensin 2 is the stimulus for zona glomerulosa to release aldosterone. When I talk about the HPA axis is only for cortisol. You look at it here again clearly. Your HPA axis only causes ACTH to effect on cortex at zona fasciculata and reticularis. Fasciculata and reticularis, where fasciculata for your cortisol, your sweet hormone, and your reticularis for your androgen. They do not, ACTH does not stimulate your cortex, which is zona glomerulosa, to release aldosterone. They are stimulated by angiotensinogen, where based on your JGA receptor. That day I mentioned about juxtaglomerular apparatus, right? So juxtaglomerular apparatus, when they have a low renal perfusion, it means patient is hypovolemic. Low filtered sodium, patient is hypovolemic or hyponatremia. Sympathetic activation means patient BP is low. BP low, hypovolemia, hyponatremia. All these are sensor at juxtaglomerular apparatus at the macula densa. All this will cause secretion of angiotensinogen. Angiotensinogen will be converted to angiotensin 1 by renin. Renin, after angiotensin 1 will go to your lungs, where angiotensin converting enzyme will convert your angiotensin 1 to angiotensin 2. This occurs in your lung. This occurs in kidney. Okay, I'll go through here. This is kidney, this is lung. Angiotensin 1 converted to angiotensin 2 in lungs. In lungs, after it converts to angiotensin 2, the angiotensin 2 will stimulate your zona glomerulosa to release aldosterone. Aldosterone will go back to kidney, where it bound to mineralocorticoid receptors, MR, and it will cause sodium retention, potassium wasting, and metabolic alkalosis. So when patient has hyponatremia, sodium will be retained. Patient have hyperkalemia. Hyperkalemia also a stimulus for this, where sodium will be secreted. Okay. Again, we come in here, drop in blood pressure, a drop in blood volume, hypovolemia or hypotension or hyponatremia. All this causes renin release from kidney. Renin is released from kidney, angiotensinogen from liver. So renin will convert angiotensinogen to angiotensin 1. This angiotensin 1 will go to lungs, where angiotensin converting enzyme within the lung will change angiotensin 1 to angiotensin 2. Angiotensin 2 goes to two places. One, it goes to the zona glomerulosa of adrenal gland to release aldosterone. They also act directly on the vessel, causes vasoconstriction, causing increase in BP. Vasoconstriction, increase SPR, increase BP. But they also need to increase the volume. So they go to adrenal gland to release aldosterone. Aldosterone goes to kidney to stimulate reabsorption of salt and water, sodium and water retention. Okay, so this is how it works. So this is the overall everything I've mentioned. Go through from here. You go through from here slowly. What happens? You will understand exactly until the end how this renin angiotensin aldosterone system